If you're considering having a facelift, there are many techniques that can raise and tighten your face. However, there is one area of the face, in particular the mid-face, which is commonly overlooked by surgeons. I have been performing mid-facelift surgery for the past several decades and with success. Today I have as my guest a colleague and friend, Dr. Allan Wulc, who is going to describe the techniques that he uses which have advanced the field further. Tell me, what defines a mid-facelift?
You know, as an oculoplastic surgeon, somebody that does plastic surgery around the eye, I always found it a little bit unsatisfying that you could make somebody look great around their eyes and they'd still say to you, well, don't I need a facelift? Because the changes that occur around the eye with aging aren't all inside the eye or around the eye. They're associated with, proximal changes that are close by. So every patient would say, God, I just wish you could do this, pulling up on their cheek. And the answer was, invariably in the early days, well, that would take a facelift. And so that patient would usually be sent to somebody else who was an expert at facelifts. But it turns out that using endoscopic techniques or techniques with incisions that are remotely concealed, you can actually give the patient exactly that. And it would improve the whole eye area because you would improve the what's called the lid-cheek junction, where the lid and the cheek meet, which tend to sag as we age. So pulling them up, giving the patient exactly what they want, putting something there like a suture instead of a finger, and getting a long-lasting result was something that I added to my practice around 24 years ago.
Why is this mid-face area so important?
A heart-shaped face is the kind of sign of youth, and as we age, as things sag, the face gets fuller below, and instead of looking like a heart, it looks like a pear, and that's undesirable. So, some things that people do to, especially early on, to right that wrong is fill this area up with filler, and that improves things. But actually, what's going on is at multiple levels. We have it's skin, it's gravity, and its volume changes. But if you lie down and look at yourself in the mirror and go from the upright position to the supine position and just look at the changes that occur in the cheek, actually lying down changes the vectors of gravity and makes your face look heart-shaped again. So a lot of this is due to gravity. So it stands to reason that lifting the cheek can improve the face. And it turns out that that's the case, and it's actually long-lasting.
But there's a lot going on there. There's bone, there's muscle, there's fascia, there's fat.
In the skin, what happens is that it loses elasticity, and it loses, actually thins and loses some collagen, and the collagen becomes disorganized. And that's largely an effect of the sun. The sun's rays actually are bad for you. You get areas of pigment, and also areas of pigment loss. And as it loses attachments, you get wrinkles. And so that's the skin. So the muscle actually doesn't change much. There's some evidence that there's a little bit of thinning of muscle, but that's not really where the action is. And in the bone, that supports the eye, the orbital rim actually involutes. It actually moves inward, but not at the same speed as
So it's turning inward?
It actually turns inward. Actually, the cheekbone and the jaw actually kind of pull inwards, and they move internally. So this whole area collapses. And because it collapses, and the orbital rims also collapsed a little bit, what happens is the eye, the orbital fat pads tend to sort of tent forward. It's also been shown that in the layers beneath that, there's a septum. There's a fibrous layer that actually runs from the orbital bone to the eyelid, or up to supporting tissues of the eyelid, and that gets thinner with time, allowing the fat to move forward, seemingly to herniate, although there are really no herniations that actually occur. It just seems that way.
First of all, you're calling this, the technical word is orbital malar ligament?
I wasn't talking about the ligaments yet. I was just talking about the orbital septum. So the tissue between the arcus marginalis, the bone that attaches to the rim, and the eyelid, or which actually attaches to the tarsus, the supporting layer of the eyelid, actually thins, and you can see that difference when you're operating on young versus older people. It's thinner, but it doesn't actually, the fat never actually pops through. It's just thin there, and so because of the thinness, you actually get bulging. There's also so that's above. Below there are ligaments. There's the orbital retaining ligament, which actually supports the cheek, which runs from the along the inner canthus all the way out laterally, and it supports the cheek. And then there's the zygomatic cutaneous ligaments, which run here. So they're sort of like the structural tissues that hold the deeper volumes and the skin in place. And there's no studies that show that the zygomatic ligament changes, but there are studies that show that the orbital retaining ligament actually thins. It's multi-layered and it thins and lengthens, allowing the fat pad, which it envelops, to droop. So we've gotten to the ligaments, which actually probably may or may not be the same, but what definitely happens is the fat compartments, which sit in the cheek and actually extend all the way down to the jowl, change with time. What happens with them is that there's two layers, actually. It's like a sandwich of fat. The deeper layers of fat actually thin. And what happens because they thin is that the superficial fat layer actually also falls forward. So basically everything's sort of collapsing on the ligaments. And what you see in people as they age is you actually see including in me, you can actually see the ligament kind of outlined in the shadow here, and another ligament outlined in this shadow as things are drifting. The volumes are drifting, the ligaments are staying the same. They're hanging on for dear life, and so but you see those volumes, and because the ligaments are in place and holding things, by eliminating the effect of gravity and laying flat, those changes disappear. Even though there are bone changes, even though there are skin changes, and even though there's volume shifts and volume loss, if you can actually achieve a reasonable rejuvenation by laying flat, it makes sense that all you need to do surgically is allow the patient to lay flat, staple everything in place, and then allow them to get up. And technically, they should look great. And that's actually what a mid-facelift actually kind of does.
But what about volume replacement when there's fat atrophy or muscle resorption? Bone resorption.
So the ideal facial rejuvenation procedure isn't just a lift. It's a combination of restoration of every element that's actually changed or been lost over time. So ideally, you will supplement volume loss with additional volume, whether it be fat or filler. And in general, I prefer fat. And if there's changes in the bone, you can do bony augmentation. Though in general, I think you can achieve a lot just with volume augmentation. I personally don't do bony volume augmentation. That it can be done.
You mean with implants?
Implants, and actually, including like hydroxyapatite, which is a coral, which can actually be inserted under the periosteum, under the tissue that envelops the bone, to actually supplement and create the illusion of additional bone, or a silicone rubber implant, or other implants that integrate.
In my experience, I think a lot of mid-face issues can be addressed with a facelift. So why go through this idea of doing a mid-face lift as a specific focused treatment?
Well, there are a lot of reasons. So first of all, again, this was, I sort of initiated this as a adjunct procedure to improve the results of eye surgery, blepharoplasty. But a lot of patients don't want to have a facelift. Facelifts are associated with long expense, the possibility of looking like a freak, which is less likely but still possible, an incision around the ear, prolonged recuperation, and they don't want their friends to know. So the mid-facelift is a procedure that's done with completely concealed incisions up in the temple. It's really the patient can say they had their eyes done, and this is sort of done at the same time as a little extra, but it really provides I think an incredible aesthetic improvement over a blepharoplasty alone, which still leaves the face looking pear-shaped. So you're right. If you're doing it, if you're planning, if there are extensive aging changes in the jaw, along the jawline into the neck, a lot of times the patient will benefit from having a facelift and their eyes done at the same time. And when we definitely do that procedure when necessary, but the advantage of doing a mid-facelift at the same time as you're doing a blepharoplasty is that if somebody's contemplating facial surgery later, you don't need to go back in and do it. And as you know, doing deep plane facelifts, the most confusing area and the area of greatest concern and risk is when you're actually cutting these ligaments to try to find the muscles that lift the cheek. There's a lot of risks and a lot of unfortunate cases of paralysis that occur. So I've never seen a paralysis from a deep plane mid-facelift. When you're doing a deep plane facelift, which is incredibly and there are so many expert surgeons at this, you have to cut all these ligaments. The ligaments, you have to find the zygomaticus major muscle, which is one of the smiling muscles, and supposedly going underneath it is the nerve that animates the eyelid area, and also sometimes even the mouth. And so that's, you're kind of after you cut the ligament, you're traversing through layers of fat, praying, looking, staying superficial, and hoping that you're actually going to get it. You find the zygomaticus muscle, which is often encased in fat, and actually, you can only tell by lifting the face and seeing this thing that attaches at the mouth. And it's not done with magnification unless you're wearing special magnifying eyeglasses. But sometimes you use the muscle that closes the eye, the orbicularis muscle, as a landmark, and you go to the muscle, you find it, you lift it up, and then you can usually find the zygomaticus major muscle. Well, with a mid-facelift, the way that I do it, and others, you actually go underneath the muscle with a magnifying view, and you actually gently separate the zygomatic ligaments, and only a small portion of the ligaments need to be separated. You're looking right at the zygomaticus major muscle, and you're actually internal to it, so you can't injure the nerve. You just can't. It's impossible. You're actually going with a device that's actually stiff. So with a 9x 30x view, so you can really see everything really clearly. And so you actually elevate it and then suture everything in place, and you have a long-lasting result without the need to go to that area and open everything up, looking for it and hoping that you find it. And usually, again, experienced surgeons find it, but it's also sort of terrifying until you do. That's not the case with the mid-face, when you're doing it endoscopically.
Why would a patient want to undergo your procedure, which we're going to talk about in greater detail in a minute, versus, say, doing fat injections? Because I know you do fat grafting, and I don't really see. To me, I could fat graft the mid-face and the lower lid and the eyelid mid-face junction.
So again, you want to do like for like. So if there's volume loss, then adding volume is a great thing to do. But if it's a gravitational change, adding fat and praying that you're going to get a lift is completely fallacious. It doesn't happen. So we actually looked at this in a study that we did actually in 2016, which is yet unpublished. But we did it with filler. So we looked and we injected the lower eyelids in the cheek using registering the patient in 3D using a Canfield camera, so that we could actually see what changes occurred. Then we'd inject the patient till a dramatic result by both the physician and the patient was achieved. So usually, that was 5 to 7 syringes, and this is all done at my expense. This wasn't covered by industry. This is, it's just because I was interested in it. And what did we find? We found that, no, you don't get a lift with products that have names like Lift. Instead, when you injected, and it was specifically with hyaluronic acid products, what you got was an expansion. So you did get a dramatic result, but it was in the z-axis, and what happened, and sometimes in the y-axis, in the x-axis. But what was interesting is in the y-axis, you actually got went down. So instead of expecting a lift, you actually got a depression. So you did not get the benefit. Now there's another study that was done in cadavers, looking at fat and whether augmentation with fat would lift. But that study was done in cadavers that were flat, were laying flat on a table. So there was no way to actually measure the benefits of it. So I do think when you're laying flat, you will get expansion in any axis you want, but it's not one that you can measure clinically, and not one that actually works to the benefit of the patient. So, and I know you see this in your practice, is a lot of patients come in and they have needle fatigue and they look worse. In addition to having swelling down here, everything's sort of pulled down. Their faces may look heart-shaped, but the heart is down here. It's not in the right place. Again, because the gravitational elements were not acted on, and if anything, the filler actually made the face sink.
Yeah, but most of the time, in my experience, the practitioners injected the material in the wrong place to begin with, and they look sagging or overfilled or whatever, But I agree with you. I don't think it lifts. I think it just expands.
Exactly, it expands, but it actually drops. Now, you talk about practitioners. So, in my area, which is the Philadelphia area, there are some patients that go to med spas every 3 months to get their tox, their Botox, or their equivalent neurotoxin. And every time they're there, they'll get filler, because it's somehow equated. You get to Botox and filler, and so
part of the package.
Yeah, it stands to reason that you're going to get overfilled, and it stands to reason that overfill could either migrate or drop. So I don't know that injectors are putting it in the wrong place. Unless you're in the room with them when they're doing it, it's hard to imagine that. But it's definitely the case that we're seeing, and I know you're seeing this. The first thing that has to happen before a procedure is you need to dissolve the filler, because it's in the wrong place. It's causing some of the problems that you're expecting. And then if you're going to augment them with fat, which is a lighter substance and more natural, it's better to have them in their native state than to have filler kind of sitting there clogging the works, and also not telling you what the end result really should be.
So let's talk for a minute about your approach, which is, you call it perioculoplasty.
So perioculoplasty means that you continue your dissection after a brow lift around the eye. So you elevate the whole orbicularis muscle, and you just elevate the orbicularis muscle, and that provides a mild lift to the cheek. Sort of like what you lift here will cause adjacent changes. So if you do a brow lift, a lot of times you'll get a little bit of improvement in the cheek. Sometimes if you do a facelift, you'll get a little bit of improvement here too, because you're releasing some of the ligaments. So it's sort of like everything you do has an action reaction. But if you if you do perioculoplasty and you elevate the orbicularis, you do get a little bit of improvement in the cheek. But otherwise, when you're doing a mid-facelift, you're actually going below the orbicularis, dissecting off the ligaments, including the medial part of the zygomatic ligament, going below into the midface, and actually suturing the midface volume in place too.
I've watched you do it. I know you're a master at doing. But what about the plane of dissection? Because there's some people like Dr. Wulc and his associates go in a subperiosteal plane. You're going in a pre-periosteal plane.
If you're going under the periosteum, you're basically going on top of the bone, and separating the bone from this layer of tissue that actually provides blood supply to the bone. So if you're assuming that over time, you're actually depriving the bone of blood supply when you're doing it, that's the first issue. So you don't age where the periosteum is. Everything ages on top. You pull this up, that's fine, but if you grab inside and you pull, you're not going to get the same benefit. So the problems with those procedures, and I respect Dr. Hulk a lot, and he does great work, are that you have to deglove the entire face. You have to take everything off. You have to release. You're not near any ligaments, so you're not dealing with any ligament issues. You're not dealing with any fat compartment issues. You're just actually cranking everything up, and you're actually lifting the muscles, including the smiling muscles, up into this area. And what it does is it actually, I think, distorts the face. It widens this distance in an unpleasant kind of way. And because you've actually elevated everything, you also, to that extent, in addition to getting a really fat face, you get prolonged swelling. How do you hold that in place? Well, people use these things called tines to hold them in place, which are inserted, and they absorb over time. They're painful. They can get infected. They can cause they slip. So I think that there are a lot of disadvantages to that technique, but I know surgeons do it. I think that, but again, we don't age there, and you can't deal with fat loss there. You can't deal with ligamentous changes which are occurring, which we can deal with a periosteal approach, because with the pre-periosteal approach, you're dancing around the nerves, you're dancing around the ligaments, you're seeing all the structures you need, the fat and the muscle, and you're actually elevating them. So it's very natural. Also, if you're arguing about the deep plane, there's some surgeons that actually do the endoscopic part of the surgery. They do the facelift using an endoscopic technique first to get there, and then they do the neck part and lower part of the face using a conventional technique. So I think that, and some of the surgeons obtain incredible results. So it's great to have both of those. Options when you're doing a facelift.
What do you think about, I'm going to mention the authors Codner and Hester and McCord's approach through the eyelid, because I've used that technique and I've gotten some very good results.
Trans eyelid means going through the eyelid, and that's incision either in the corner of the eye, under the eyelashes, or transconjunctivally, where you actually have to dissect the orbital retaining ligament off, and you can go either in the preperiosteal plane or the subperiosteal plane. So you go under on top of the bone, or dance again among the below the muscle, finding the fat pad, lifting it and suturing it in place. So specifically, when Codner, Hester, and McCord described this in their study, which I reference all the time, their complication rate was 19%. So I've seen some of patients who've had that procedure of that sort. In fact, I'm reviewing a record now of a person that had 6 surgeries in Beverly Hills and 1 in Atlanta. All of them done trans eyelid.
I saw one in New York. They had 13 operations to correct mid-face sagging.
1 in 5 people who had that approach develops a droopy lid. And if you really anger the lid margin, you get scarring here between the orbital septum, the supporting tissue, the tissue that kind of insulates the eye fat, with the orbital retaining ligament, you get anger at this area right here. You get this contraction. This pulls down, and nothing happens here, and you get this line that goes across here. So back in 2007, when that technique was incredibly popular, I presented a talk, and with Chip Cole and Susan Hughes, both whom are excellent surgeons, on disasters of lifting the midface using that approach. And yesterday, I reviewed a chart of a woman who's actually paralyzed in her left eye, who's had 6 surgeries, and again, not by people. These are by people that are famous. These are people that have published a lot, who train fellows, and who are very respected.
They're not infallible.
Well, no, it's that's true. But when a person says they have good results, and I think that there are surgeons that have great results with these techniques, but those surgeons aren't me. And I've definitely seen others.
Yes, they are.
No, I don't. I just don't. I don't do that approach if I could possibly avoid it.
Okay.
And while I did have some triumphs, I also, again, back then, I included my patients in that group too, and and so we see those things. And again, part of the learning curve when somebody talks about how great something, and I remember jumping on this idea of okay, well, I'll just do a little bit more in my blepharoplasty and lift this up, which is what the promise of the Rod Hester McCord and Codner procedure promised, and I was astounded by how bad the results were. And then I read the small print about the 19% complication rate. And his one of the fellows, one of the group was in the audience when they talked at the same meeting. So they were the feature presentation, and I was this person that was relegated to a 5-minute talk about disasters of lifting this. And I don't, so that fellow actually intimated to me that they see a lot of complications, and some of those complications are impossible to reconstruct for a variety of reasons. They get a defibrillated scar, they're paralyzed, their eyes dry, it's incredibly uncomfortable, and they can't go anywhere without drawing attention to themselves. And again, the problem wasn't corrected because the problem is this, has nothing to do with this. Which I want to talk to you about. One other thing about that is that do you need to separate the orbital retaining ligament here when you're doing a mid-facelift? And the answer is no. So you don't need to do that, because if you do it, you still get it angry. So, what I mean by that is it's fibrous tissue. It's fibrous tissue forms fibrous scar, and it contracts. And it's got, myofibroblasts in it that actually contract. So if you're going to create a scar through here, you have to live with the possibility that that's going to pull the lid down over time, even if you're doing a cheek lift, from laterally. I mean, it's easy to get here to disrupt this, but I don't think you need to.
What do you think about the vector, though? Your vector is kind of oblique versus a more vertical vector.
So that's absolutely true. So if you draw a line between the corner of the eye and it's about 3 centimeters away, you're actually grabbing the orbicularis muscle. That's where it is. So if you're pulling in a directly vertical direction, you get a vertical lift. If you go 2 centimeters away, you're still safe, and so you can grab the orbicularis muscle and get a vertical lift, and you can attach it above. You can also attach it to where the ligament should be that's sagged, which is right here. So you can actually attach it directly if you're adept with a scope, and you get a lift. You're absolutely right that you're not getting a vertical lift across here. So how do you get a vertical lift across there? Well, again, I don't think that disrupting this ligament makes a difference. In several cases, we've done disruption on one side and no disruption on the other, and there's no difference in what you achieve. So it looks exactly the same postoperatively. We published that. But in order to improve and get a lift in this direction, what some surgeons do, and I do infrequently because we really don't need to do that, is take the fat that's here and move it down. And by doing that, you actually inadvertently, maybe intentionally, pull the muscle and the skin in an upwards direction. And that's been shown by John Holds and I think Stephen Couch in a study they did. So you can, with an incision under the eye transconjunctivally, grab the fat pockets, pull them down here, get a little bit of a lift, vertical lift here, but it actually lifts the muscle in a purely vertical direction. So what they showed was they actually measured where they did a study where they actually measured, you couldn't measure the lift, what they measured is how much muscle from below they were able to recruit in, and also looked at an improvement right in the tear trough. And it was actually really dramatic and really convincing.
So the fat was a hinge to pull up?
It's adjacent fat transfer. So you take the fat as pedicles, and after mobilizing it and freeing the area up, either.
I've done that, but I've never observed.
I can send you the study. It's actually really interesting, but probably some of your best results. So, we don't always know what we're doing. So, but I think it's
a
really,
little bit of luck. Yeah.
You say, well, the tear trough has gotten better. That's definitely true.
Yeah.
Right. And so you're looking at the tear trough, but you're not looking at the shift in muscle position. You're not looking along the lid margin to see how much more muscle is there, and you're not looking at the vertical lift. So Deepak Ramesh and Alan Bracker and I think Bob Goldberg and I did a study on the tear trough, and whether doing a blepharoplasty alone or the sharing technique made a difference. And what we found was that the sharing technique. It just depended on your taste, what you liked better, because even a blepharoplasty alone improved this whole lid cheek junction. But if you want to lift, I think in this area, like you were pointing, what about a lift here? Then it makes sense to consider doing an adjacent fat transfer, taking fat from below, putting it in below as a free graft, and what it does is it sort of interpolates the orbicularis muscle into a more upwards position along with the skin that it's attached.
When you say free graft, you're not saying it's attached as a pedicle?
It's sort of like this. It's in appropriate selected patients. And what that means is it doesn't work in everybody. And not only that, an appropriate selected nobody's actually saying to you what is an appropriately selected patient. So I've asked that question of people that do a lot. I don't do much adjacent fat transfer for a variety of reasons, because we do fat grafting. So I get exactly the kind of lift I want, and I fill the lid cheek junction with fat. But what I think I've heard people who do a lot of this say is that they reserve those cases for patients who have prominent eyes, and it's called negative vectors. The eyelid has a tendency to sort of droop a little bit, and so their thinking is that by putting the fat in here, they're going to obtain a little bit of an elevation of the skin in a vertical direction.
I think there's an inadequate amount of fat in most cases to fill in that nasojewel groove.
I totally agree. And it adds element of complexity. You can get double vision. I've seen it. You can get numbness because if you're going subperiosteal, because you're near the one of the nerves, the infraorbital nerve. So you get numbness around the lip. I mean, and have I seen it? Yeah, I've seen it. I've seen double vision too. It's very disconcerting to patient one day post-op with a fat pad sutured in place who looks fantastic, saying, "Well, I have double vision. Is it going to go away or not?" So it's so you don't like that.
Yeah.
So that doesn't happen. I think if you're doing just conventional blepharoplasty with fat augmentation with fat. So the only time that I personally will do adjacent fat transfer is if the patient has no body fat. And really wants volume augmentation in the tear trough, and that's their main goal. But I'll still tell them about the risks, including the scarring at the orbital rim. And in addition, I'll tell them about the possibility of numbness and double vision. Usually that goes away. Talk to other people who do a lot of it, and they'll say, "Well, yeah, that does happen."
No big deal. No big deal. Yeah, you and I would lose sleep over that, but
I just wonder what the advantage is when you can achieve the exact same result with a much more benign approach that's long-lasting and without those associated risks.
Well, I mean, there's risk for fat grafting as well. So I mean, you get granulomas and et cetera, et cetera, et cetera.
Yeah, no, you're absolutely right. I mean. And some of those, I think, are because of sharp needle grafting. So if you're not using a sharp needle, you're doing it carefully. You know what you're doing. You know the anatomy. You're away from the blood vessels. Theoretically, that shouldn't happen. But you're absolutely right that bad things can happen to good surgeons in spite of all that. So. I still think adjacent fat transfer for me, and everything's about a learning curve. So I've been doing fat also since about 2000. Adjacent fat transfer I think I probably did that then too. And I had some discouraging experiences at that time, so that kind of drove me away. And that's why it's called the practice of medicine, practice of surgery. You practice and you go, that didn't work for me, so I'm not doing that anymore. And you adopt something that's more dependable and that works in your hands.
Right. And I found that also when you do fat transfer, it's hard to sometimes assess how much fat to actually transfer into the hollows, because you've inflated the area with lidocaine and there's swelling, surgical swelling, and therefore when you release the fat, you're now moving the fat pedicles in, and there's a little uncertainty in terms of symmetry between lower lid.
Every procedure that I do, I hang a picture of the patient in the room, along with a picture of them younger. Now, usually they're smiling, so when the midface is elevated, it sort of creates a sort of a smiling effect. when they're lying flat, they also have a smiling effect. So you kind of have an idea of exactly where things should go. And again, based on experience, which is something that we both have, given gray hair, et cetera, I think you have a clear idea looking at the photographs of what you need to do. But you're right that it's definitely possible to undershoot and rarely overshoot the mark.
How about those pesky festoons? Those festoons. How many people ask us about that?
A lot of surgeons just give up on festoons. And so, see, again, I personally don't think that a mid-facelift addresses festoons. I think it helps, but I think the reason that it occurs is unexplained. Maybe it's lymphatic obstruction, maybe it's poor circulation, but it's unclear. But what we know is that in the area, so a festoon basically is just at the base of the lid cheek junction, where the muscle that closes the eye ends, and where the muscle that smiles begins. There's this roll of tissue, and it can be either dry, like just sitting there, excess skin, or it can be wet, which is this boggy mound of edema. So the edema, it occurs at every layer in the interface, and so there's the way it goes skin. In this area, it's skin, and then fat, and then muscle, and then fat, and then this attachment. So where's the problem? So it's probably at every one of those locations. And so what we've done in the past, with some success, is use radiofrequency energy on the superficial fat pad to improve it and also tighten the skin. We've used laser to tighten the skin, and maybe we get some improvement in the fat. But again, most of the action is in the deeper layers, at the where the fat attaches to that septum. So a perioculoplasty, which is again not necessarily a mid-facelift, tightens that area, and it tightens the interface between the two. And if you rupture that area, if you actually bust this septum, the orbicularis, where it attaches all the way to the nose to the muscle, what ends up happening is the patient gets prolonged swelling. So I don't like to do that. So we'll do a much less invasive elevation, and in conjunction with laser, again in the appropriate patient, and the patient has to have relatively pale skin.
So you found that microneedling with radiofrequency helps?
Yes. So we had a paper accepted to the Aesthetic Surgery Journal, which we're actually re-reviewing, because I don't think that our data was as rigorous as I'd like, but we definitely had improvement, at least of one degree. If you measured festoons from 0 to 4, which 4 being the worst in the whole world, 0 being not there, we were able to get an improvement of one grade in every patient. They all were treated 3 times and followed for 6 months. Does it last? I don't know, because I followed them for 6 months. But I've followed patients anecdotally, and it does last. So it lasts, seen them 1 or 2 years later. Laser works really well on appropriate patients too. Why laser alone would work when, again, the action is occurring at a much deeper level is a mystery to me.
Yeah, I've had some experience with laser, being aggressive with the laser and shrinking, but those are primarily festoons that are skin based. They're not the deep boggy ones that you're talking about.
I totally agree with you.
Well, I think we've covered the waterfront mid-face. I really appreciate your time, your expertise, your friendship, and it's been a real pleasure to have you as a guest on the Beauty Doc podcast.